I wanted to just share the confusion about vitamin D. And as you're all well aware, we're still swimming in a COVID pandemic, and there's still lots of information coming in about vitamin D and COVID. I actually looked on PubMed today. And this year, we have published 2 papers every day about vitamin D and COVID. And we are publishing 16 papers a day on vitamin D. How is it possible that we are still confused? These are my disclosures. The real disclosure is when you see the orange text color, that's my opinion, and you're going to see a lot of orange, and this is largely all my opinion. This is just an illustration of the controversy surrounding the 25-hydroxy D level to use. These are authoritative groups here. There are a few experts here. And basically, the threshold varies from 12 nanograms per mil to 20 nanograms to 30 to 40. That doesn't sound like much. What's a few nanograms per mil among friends? This is why it matters. These are NHANES data. And if we use a cut point of 12 nanograms per mil, 7% of the US population is D deficient. If we use 50 nanograms per mil, 97% of the population is D deficient. Sorting this out is important. Why have we failed? And this is just a summary, and I'll talk about these as we go through, but basically, we're not sure what we should be measuring. We're assuming that circulating 25 is the correct analyte, and that may not be true. We're still not measuring 25 well. We don't know if everybody needs the same level. We're assuming they are, but that's probably incorrect. This is important and recently being recognized that 25D is indeed a negative acute phase reactant. I'll share with you what I think is going on with a lot of the associational literature, and that's reverse causality. And finally, the RCTs are just fatally flawed, and therefore meta-analyses of fatally flawed trials yield fatally flawed conclusions. So why was 25 selected as the test to identify an individual's vitamin D status? Here's personal communication with, I think, 3 of the folks who know more about vitamin D than almost anybody on the planet. Hector DeLuca, I think all of you recognize that name. Hector said, well, there's a bunch of it in the blood, and it was the first easy assay. Well, not so much. Chris Sempos, the head of the vitamin D standardization program, said, well, there's a long half-life. The 25 hydroxylation step is unregulated, and therefore it reflects substrate availability, and we can measure something. And finally, the late Professor Robert Haney said, well, it seems to me that we should not only look at 25, but we should look at circulating D3, cholecalciferol. This is not an overwhelming endorsement that this is the right analyte to measure. And I think some of you have seen this slide. We're measuring 25 in the sea of other vitamin D metabolites, and at least some of these metabolites possess a vitamin D-like effect. Known examples include the 3-epimer and 24,25-dihydroxy-D. And this is just a list of the ones that we think are important. As Haney said, cholecalciferol, the 3-epimer, and that's present at about 5% of the total, and 24,25 that's present at about 10% of the total, and there may well be others. It seems reasonable to me that we should be measuring everything that has a vitamin D-like effect rather than just 25. I see virtually no research being done to consider that possibility. So we're stuck with 25. Then the question is, does everybody need the same level? I put this again to Hector, and for those of you who don't know Hector, he's published about 2,000 papers on vitamin D. He got his PhD in 1955, and he's still active in the field. So his knowledge is encyclopedic. And Hector says there's really no evidence to support using the same level in everybody. And indeed, this was recognized by the USPSTF update just this year, when they said vitamin D requirements vary and there is no 125 level that defines the correct value in all individuals. But we are currently stuck assuming that 25D is the analyte to measure, and we're assuming that we all need the same level. Unfortunately, there's no way to determine the vitamin D status of an individual, and if you're a patient or you or me, if our bodies believe we're seeing enough vitamin D. And Joe mentioned the 25 to 24, 25 ratio. This is a possibility, and some have advocated it in that high PTH leads to less degradation, low PTH due to more degradation. I think that enthusiasm for this is tempered substantially by the fact that PTH can be affected by calcium intake, and the assays are not ready for prime time. I think probably the Mayo does the 24, 25, and 25 better than almost anybody. But here's a publication with a number of pretty doggone good laboratories and 5 serum samples sent to those laboratories. And this is the 24, 25 level, and it's all over the board. So you've got a variability in your 24, 25, and you've got variability in your 25. This is the current DQuAS data from this summer, and these are mean values. Each of the different colors is a different assay, and the red bar is the true value, the NIST-assigned value. So you're making a ratio of one variable assay, 25, with another variable assay, 24, 25. I think that if we're going to go down this road, the assays clearly need to be standardized. This is not a new concept. Here are just a couple of examples where the prevalence of low vitamin D at various cut points matters, whether the data is just run routinely or with standardized 25D. This is actually being recognized, and this may be the first step forward. And the journal Public Health Nutrition recently brought this editorial forward and said, we are going to require that papers published in PHN report standardized 25D levels. If we did that, then we could have rational pooling for meta-analyses. But even if we magically standardized everything today, pardon me, it's my opinion that we need to appreciate that circulating 25 is a negative acute phase reactant. It's reduced by illness, inflammation, surgery, etc. And here I think is a really elegant study documenting that that happens and that it happens right now. And this is a tiny study where they gave 9 healthy men, in essence, gram-negative sepsis. They gave them a bolus and an infusion of E. coli-derived lipopolysaccharide. They measured 25D well by LC-MS, and the 25D went down, natering at 3 hours, correlating to the cytokine increase. It was reduced 22% within 3 hours. And because the world's focused on COVID, these authors were focused on COVID. And what they concluded is, as you see here, that the 25D levels decrease practically immediately with a systemic inflammatory reaction. It's my bias, the orange text there, that this happens with a multitude of other acute and chronic events, and that reduction in COVID, at least, occurred before the patients got to the emergency room. And that, I think, raises the possibility that reverse causality is going on to explain the association of low 25 with the multitude of chronic illnesses that you've all heard about. It basically runs from A to Z. So what do I mean by that? Well, a causal association is that the risk factor causes a disease. Reverse causality is that the disease causes the risk factor. I would argue that this is what we're hearing, that the low 25 is causing you to get COVID, causing you to get sick from COVID. I would suggest to you that maybe COVID is causing a reduction in 25. And specific to that, it seems possible to me that the infection reduces 25. The sicker you are, the greater the inflammation, the greater the 25 decrease. So I think this belief that, well, I'll just take vitamin D and that'll keep me from getting sick from COVID, this is probably reverse causality. What's really going on? I don't know. So is this reduction in 25 that happens right now, is that simply an assay artifact? Or do these low circulating levels indicate tissue or cellular deficiency? And could this also be the case in chronic inflammation? So as you're well aware, chronic inflammation is observed with a multitude of other diseases. Virtually all of these have been linked to or associated with vitamin D deficiency. Is it the inflammation that's causing the low 25? I don't know. And this is a question without an answer. Well, we're doing all these big RCTs. Won't that fix it? No. Large studies with fatal biologic flaws will yield fatal conclusions. And if we would have listened to Haney a decade ago, we would have understood this. And so what Bob said is we need to think about this sigmoidal curve, intake versus benefit. And if you're deficient, giving you more is going to have a benefit. If you're sufficient, not going to matter much. And if you've got enough, giving you more, the only possible thing it can do is make you toxic. And, you know, this is what we're seeing in the New England Journal. Daily supplementation with high-dose vitamin D didn't reduce the incidence of cancer or cardiovascular disease. Well, if you look at the supplement to that article, you see that their average 25 hydroxy D level was roughly 30 nanograms per mil. If we would have listened to Haney, we'd have said the replete, an increase in intake will not produce an effect. This is exactly what you would have predicted. Here, I think, is an example of toxicity in our field. So this is a 3-year RCT of folks who had enough 25D when they started the trial. They then gave them 400, 4,000, or 10,000 IUs, and lo and behold, their radius BMD by PQCT declined. Again, what we would have expected. If you're replete, the only thing that giving you more can do is cause toxicity. Moreover, the RCTs are flawed by failure to recognize that we're not the same, and they give fixed doses. All of you have seen hugely different responses to a fixed dose. Here was 2,500 IUs per day, and you can see the huge between individual difference pre to post after starting 25D. It seems logical to me that we would use a treat to target approach, not being done. Clinically, as a generalization, you can expect 7 to 10 nanogram per mil increase from adding 1,000, but huge between individual variability. So in summary, we're not sure what to measure. We're assuming 25. It's rarely reported as standardized. And in my opinion, that precludes these meta-analyses that are commonly being done. We're ignoring the concept that we're all different. We likely don't need the same level. We respond to oral dosing differently. Moreover, we don't know where people started. They were often vitamin D replete. We don't know where they finished. We've ignored largely the effect of inflammation on circulating 25. It's my bias that this explains the association of virtually every disease from A to Z with low 25 hydroxy D status. And finally, the studies have recruited folks who are D replete and given fixed doses. And sometimes the doses are pharmacologic. we have not differentiated vitamin D supplementation from 100,000, 500,000 units. Those are pharmacologic doses. So the evidence is flawed. What do we do? Well, I think we apply common sense. Common sense says that our genome hasn't changed much. Bruce Hollis, almost 20 years ago, said, let's use lifeguards. If we do that, where are we at? We're somewhere between 36 and 46 nanograms per mil. I think it makes sense to aim for 30 to 40. That often requires 1 to 2,000. Recognize variability. In the DEXA field, we're well aware of the least significant change. Most of us have no clue about a least significant change of our laboratory tests. With 25D, that a CV, coefficient of variation, of less than 10% meets the vitamin D standardization protocol for being a good assay. That means when your patient gets a 30, it's really 36 to 24. Here, I think, is a reasonable approach. I don't really care what value you want to target. If you think 20 nanograms is right, recognize that your patient's real value is somewhere between about 15 or 25, shoot for 30. If you think 30 is right, it's 24 to 36, shoot for 40. Even if you're on the high side, you're not getting above values obtainable by UV exposure. Finally, don't prescribe what you can't measure. This is a paper that Don Wiebe and I put together a few years ago. It basically says that when all we have is D25-hydroxy D3, the immunoassay performs well. When we've got a lot of 25-hydroxy D2, it performs poorly. This was brought home to me a couple of months ago when one of my patients had 25D on ergo, had a 25D level obtained by HPLC. The value was 81. On the same blood sample with the UW immunoassay, it was 59. So if you're using ergo, you've got to be using a chromatographic assay. So it's my bias that this controversy is going to continue. We're not sure what analytes to measure, little progress. We don't measure 25D well. Perhaps the public health nutrition editorial is a step forward. We don't know if everybody needs the same level, and it's unclear how to define optimal. Maybe the 24 to 25 ratio will be helpful, but we need to have assays that work. We have to recognize 25D as a negative acute phase reactant, and the RCTs, and they continue to be done, are fatally flawed. So to conclude, D deficiency is common. It's important for bone. Whether it's important for the multitude of other things with which it's associated is totally unclear in my opinion, and I think confounded by this negative acute phase response. The mechanisms why 25 goes down within 3 hours are unclear. It may be a reduction in DBP, it may be a reduction in albumin, but I think that the clinical message here is don't bother to measure it in the hospital. These people are sick. It's going to be low. There's no consensus on how to define D inadequacy. Maybe reporting that standardized 25 will help that. And shooting for 40 nanograms per mil, not ergo, using 1,000 to 2,000 IUs of D3 seems reasonable to me. And I thank you.
Okay. Great. We are doing really well on time, so we have all kinds of time for questions.
So Neil, I'm really interested in this inflammatory thing, and I'm trying to remember this stuff years ago when I was a fellow. John Haddad, whose name you might know, was our section head, and his big thing was DBP. And Chris Harper and him were doing research on rats with what happens with DBP during sepsis or something. I mean, DBP is something, it does something, it binds platelets, or I mean, there's something big that happens. Do you know any of this? I can't remember it.
I don't remember that literature, Joe.
Okay.
Yeah, and you know, DBP is present at such excess, you would think it wouldn't matter. You know, I think that this perhaps naturally leads us to think we maybe should be measuring 325 hydroxyvitamin D. Because if this is just a problem with the binding protein being screwed up, but we still have adequate 325, then this is just an assay phenomenon. And to my knowledge, there is not a good LCMS, there's not any LCMS assay for free 25 vitamin D.
So I just pulled up this paper. Vitamin D binding protein, and I forget what they did to the rodents, but it sequesters monomeric actin during whatever they did to them. And so it was, and so I don't know.
Yep. Now that you mentioned that, Joe, I remember that concept. So you're saying in the setting of skeletal muscle degradation.
I don't remember what they did to. I just can't remember what they did to the animals, and I'm trying to find out. It kind of doesn't matter, but clearly, it has a role in severe illness. And I don't know whether they did crush injury or something. I can't remember. You know, we're talking about 40 years ago. But I had this, you know, it does something. And so the idea that could have something to do with it wouldn't shock me. Maybe it binds something else and I don't know.
Yeah, I really think this suggests that we have a huge need to think about free 25. And there is an immunoassay out there that purports to measure free 25. We have tried to develop an assay for free 25 and failed. I think other groups around the country have tried and failed, and it appears that every time serum touches plastic, the free 25 goes away. So I have little confidence in our current publications that are out there on free 25. The point of my talk was to say, this is why we're still confused, and we're not going to be unconfused anytime soon. But I really am concerned of all this associational stuff of low 25 with every disease under the sun, many of which are inflammatory diseases. I think that whatever is causing the 25 to be measured low is explaining a bunch of that.
We have a question from the gallery. How long after a hospitalization or an illness should we wait to check a 25 OHD? Dr. Binkley, I think your THA study found that levels increase 6 weeks post-op.
Yep. And the answer is, I don't know. I have not seen studies done where this was sequentially measured, but that's exactly right. In the little study we did where we used total hip arthroplasty, in essence, as a surrogate for hip fracture, the 25 went down about 22% at day 1, and then we didn't measure it again until 6 weeks, and it was back up. So I think 6 weeks would be a reasonable time, but it's not really evidence-based.
And how does that relate to people with fracture? Is there a similar time period one should wait after fracture or repair of a fracture?
I don't know the answer to that, but I would guess so. And again, that was the reason that we used total hip arthroplasty, in that it's pretty much impossible to obtain a baseline 25D level the day before you break your hip. So I think that that's a reasonable assumption, that waiting 6 weeks post-hip fracture makes sense.
How about just an ambulatory fracture? Somebody has a compression fracture and they're clinically doing okay. Would you wait for that?
Yeah, I think give them some vitamin D. Pick a number, 2,000, 1,000, 5,000. Give them some, and then you're going to see them back anyway. You're going to see them at probably 6 weeks, and then you can get labs that you believe.
Okay, it looks like that's all our questions from chat. If more come through, we can address them at the end, but I think for now, Dr. Shaker, let's move on.